We're going to do a subjective exam. My name is Rob Shapiro. I'm the Clinical Director of Clinical Excellence for Professional Physical Therapy. The subjective exam is one of those part of the exams that really undervalued in management and assessment. We can get a huge amount of data from the subjective exam. Some people will say up to 50 to 80% of what we can get from a good subjective exam. I think it's the most crucial part. We're going to determine the sins and identify the sensitivities that go with their patient. And the goal of following the subjective exam is to be able to form a primary and secondary hypothesis, possible method of treatment, and likely prognosis. So you get tons of data, tons of information. Interview skills. We all have multiple different types of patients. The gregarious patient is a talker. He's the one or she's the one who keeps talking, and during your eval, it's like, how are we going to get on to our next patient? So what we need to do is we need to manage that. So we need to be able to talk to them and say, we'll come back to that later. We'll talk about it more. I understand you have multiple problems. Let's focus on what you came in for, and we'll discuss it more in advance. Never lose your control of the interview, and when appropriate, touch the patient. Sometimes if the patient's okay with it, sometimes just calming them down just by touch will make a huge difference. The next patient is the non-talker. He's the person you talk to who, no matter what you do, it's yes, no, yes, no. These people are afraid. They're afraid that you're going to sit there and they're going to give too much information. So remind them, you need this information. It's very important. In order to get this data, it's important that you stop, tell them that they're not complaining, that they're just informing you of the data. And that's very important for that patient. The next patient is your aggressive patient. They come in, they say, hey, look, I've done this before. I'm annoyed. Every doctor's told me. What are you going to tell me differently? So as a therapist, you keep your voice down. Everything's calmer. You ask fewer questions. You don't interrogate. Remember doing my residency, we had to keep asking, and I felt like I was interrogating my patient. Remind them, ask fewer questions, calm down, educate the patient, win them over. Once you educate them and tell them what's going on, they will be more adapt to listen to you and to kind of calm down. So what do we do? What kind of questions do we ask? We can ask open questions. That's how I might start the evaluation. What brings you to see me today? Tell me about your shoulder, your knee. Then later on, once they start talking, you can get more detailed. You can say to the patient, okay, you have shoulder pain. Tell me more about the pain. Tell me where it goes. Tell me more about it. Then later on, at the end, you want to kind of wrap it up, a closed question which says, hey, look, this is what I heard. I heard you have pain that from your back goes into your buttock, down your leg. Does that make sense? Is that what you told me? So body charts are huge. I like to use them, and it gives me a nice idea of what the patient presents like. So on the body chart, we'll look at in a second. Look at location, the quality of the pain. Is it deep or superficial? Which will tell you different things. Type of pain, sharp, dull, achy, burning. Is it constant or intermittent? And the key is if it's constant or intermittent, you tell the patient, when you say it's constant, it means it happens all the time, nothing you can do. Sometimes you have to clarify, because sometimes that constant pain might be a varying pain. And we have to make sure we understand that. We talk about the intensity of the pain and relationship of multiple symptoms. Somebody has buttock pain, leg pain. I want to see if they're all related. So if you look at this, so the types of pain we talk about are achy pain, sometimes inflammatory, a burning pain, which just tends to be more nerve-like, some type of twinge, could be something that's going past a bone, twinging. A stiff pain is usually an arthritic pain, and pain with cough or sneeze, which we'll talk about more in red flags, might be some type of dural, push on dural tissue. So here's a body chart. If you can see, the person has lower back pain, and we have numbers. So we want to see in that pain, we name pain number 1, 2, 3. Then we want to be able to describe it. Again, you ask the patient, tell me about pain number 1. Is it stiff? Where is it? And then you want to see how they relate. When you have pain number 2, does it go to pain number 1? Pain number 2 go to pain number 3? In this patient, if you look through all those different pains, we could see how they're related to each other. And that's key during your evaluation part. Here's another example. This person is more central type pain, goes into both buttocks. So that might be a degenerative disc type person. The next one on the right is very specific, a point of pain. You'll see the check marks. Check marks mean that area is cleared. I looked through it, I talked about it. When I did my evaluation, I said, there's nothing wrong here, here, here. And we went through that. And you see that little spot, bottom right, lower back, very specific. That's more of a facet presentation. So you can start to see the body charts and recognize presentations based on the body chart. Then you want to ask them the current history, the onset and mechanism of injury. So when did it happen? How did they do it? What were you doing? Progression, did it start out, oh, I did something, I felt it right away, or something that took a little bit of time. I lift up something, 2 days later, some type of inflammatory, then I wind up having my symptoms. And what have they done so far? A lot of our patients will come to us and had PT, chiropractor. There's probably 200 different types of treatments they might have had before they got to you. And you want to see what they've had so far and how it's helped. That'll guide you. It'll guide you into it to tell you, hey, you know, they've kind of done a lot of manipulation. Maybe that's not the right way to go, but into your mind, start thinking. When you have aggravating factors, we call them AGs. So as we go through it, I always have a list in mind. I always say, for lower back pain, tell me about your lower back pain, okay? Is it, you have it when you sit, stand, walk, in and out of the car? And we'll go over what each one means later on. And how long does it take to come on the onset? You know, when I do an activity, it happens right away, or does it take time to, is it less irritable, takes time to get back? And the intensity of the symptoms, and the time to ease is key, is very important, because you wind up saying, okay, you lifted that box, and how long did it take to ease? Or it took me 3 hours for it to feel better. We know it's irritable. We have to kind of calm down how much our evaluation is going to be. Then we go into easing factors. It's valuable in assisting the treatment selection. That helps us. The patient, you ask enough questions, the patients will give you the answer. And I like my $1 million question. It's usually the person next to me, but I said, if so-and-so is going to give you $1 million, what would you do to make your pain less? And then they kind of figure it out. They'll find something. If it is something we could treat, they'll find something that can make them feel better. 24-hour history, how do they feel in the morning, in the afternoon, at night? What are the patterns? They wake up in the morning and they're really painful. We talked about sleep last night. You went to bed without pain. You woke up with pain. What was different? What positions were you in? What kind of load did you do throughout the night? Is it during the day? Is it fatigue? It might be as they go and more load over the time. And has it there, or at night, again, fatigue or seeing what they're doing. And you ask about their patterns during their work day, if working versus the weekend. Are they different during work, sitting maybe all day, during the weekend when they're more active? That gives you a lot of clue to when you do your objective exam, how much to push them through the exam. We're going to talk about red flags, which Jessica will talk about shortly. And then we talk about past history, previous occurrences. So when you had your initial injury, what was the mechanism in the past? And what have you done for it? How long did it take to recover? The key to that is you kind of have an idea. You know, a lot of these patients will had an incident, and then over the time they have it again. You start to see it more frequent. And how long did it take you to recover, and what did you do for it? What helped? And then other injuries that might have an effect on the outcome. You know, they have a sprained ankle. They have a arthritic knee, so they can't do normal weight bearing. So things like that. It's very important to ask. Social, of course, occupation, what they do. The living situation. Are they the caregiver that has to lift somebody out of bed all day? Or their mom or dad who has to lift somebody, a baby, out of a crib, etc. And recreational activities, you know, are they, you know, kind of athlete, a weekend athlete? Are they going to do a triathlon? Or are they just their athletic ability is just to get to the store is their recreational activity? So we have to kind of make sure we understand that. And then make sure you know what the patient's goals and expectations are, not just your goals. And that's the key, to understand specifically what that patient wants, not what we want as a therapist, but what they want as a patient. As we go subjective, a good subjective exam is priceless and sets the foundation to pick for the objective exam. It is a skill that needs to be practiced. You can do it repeatedly over and over again, and can take people years to get good at being a good subjective exam taker. Most of the time is how you say something, not what you say. So if you're sitting there and you're kind of behind a desk and you have your, you know, you're kind of like leaning on one side and you say it in a certain way, the patient's going to get that feeling. It's how you relate to that person. You look at them in the eye, you talk to them, you care about what they have to say to you. And it's good for good communication, and gaining additional information continues throughout your treatment process. You're always coming in, hey Mary, how you feeling? Oh, no better. Well, tell me more, no better than what? Oh, no better than last time, but overall I'm a lot better. So you have to learn to talk to these patients, communicate with them, understand what they're all about. Okay, so later on we'll start to go into now to the more of a red flags. This is Rob Shapiro. Thank you.